All right. Welcome to day 2 of our overdose prevention, harm reduction, and treatment series. Yesterday was incredible. We had such amazing speakers, and I am so fortunate to have learned from all of them, from all of you. We had a lot of really great engagement from you, many deep discussions, both within the sessions and on the discussion boards. So thank you all for raising those questions, raising those points, pushing us all to think creatively about our approaches to prevention and harm reduction. I personally can't wait to see what we'll all dive in together with on our day 2 topics. So before I turn the session over to Dr. Graves for our morning keynote, I have a few housekeeping items to go through. First, this session is being recorded, as you heard the voice say. We will make all recordings and slides available by early next week. In order to earn your certificate of attendance, you must watch a minimum of 5 live or recorded sessions by September 15th. And as a reminder, we are not able to provide CEs or CEUs, just that certificate of attendance. Please ask your questions in the Q&A tab on the right-hand side of the screen. We'll save those, or sorry, excuse me. Dr. Graves will answer those throughout the session. You're also welcome to introduce yourself and chat with your fellow attendees in the chat tab. So that is it for housekeeping. I now get the pleasure of introducing our speaker, Dr. Janessa Graves. Dr. Graves is an associate professor in the College of Nursing at WSU, where she researches inequities in access to healthcare services across geography and among historically underrepresented populations. She covers pediatric injury, mental health, poisoning, and health services research. Ultimately, Dr. Graves's work informs state and federal health policies to improve access to and quality of healthcare services for high needs populations. So today, Dr. Graves will be sharing her research with us on youth's access to mental health services in rural communities. Thank you for lending us your expertise and insights today, Dr. Graves. I will pass things off to you now.
Great, thank you. I am so excited to be here. So I'm going to share my screen. And as Megan noted, I am at the Washington State University College of Nursing. Megan, please let me know if there's any issues with viewing my screen via the chat or anything. And so I'm going to talk about access to mental health services in rural communities. I'll give a little bit of an outline of what I'm going to be working on, if my screen will advance. There we go. So I'm going to give a little bit of background and sort of the motivation behind this work and what kind of drove me to work on this. I'm going to talk a little bit about recent and relevant research that I've done at the national, state, and local levels, and then talk a little bit about some future directions and future research that could be done and areas. And I'd love some feedback. I feel free to reach out in the Q&A and ask questions, and I'll try to address those in real time. And, you know, please just, I really appreciate a dialogue rather than being sort of the sage on the stage, if you will. So a little bit of background. This is in rural Stevens County. This is a town called Chewelah. I'm not sure if anybody is familiar with northeastern Washington, but I've lived here for a little over a decade. And this is sort of where a lot of my lived experience comes from in terms of this work. But prior to this, I grew up in rural Montana and rural Illinois. And really it's part of my roots, but it's also part of what I deal with on a day-to-day basis. I have a family here and an aging parent, and I'm very familiar with some of the issues that I'm going to be talking about today. Earlier in 2021, the U.S. Surgeon General placed out an advisory on protecting youth mental health, and it was meant to raise awareness and focus efforts on youth mental health with some major tenets. These tenets were that mental health was an essential part of overall health. COVID-19 has added to some pre-existing conditions that youth have had, and I'll talk a little bit about sort of temporal variation over time. Mental health, it also noted that mental health is shaped by a combination of factors. It's biological factors, but it also includes life experiences and environmental factors. And finally, the advisory really stressed that focusing on youth mental health is very critical. And we all have a role to play in supporting youth in their mental health. This is really kind of a call to action. This advisory, it was in 2021, so it came out amidst the COVID-19 pandemic, but this has been an issue that's going on for a while. On the screen right now, you have on the x-axis year, and on the y-axis is the rate per 100,000 of suicide, rate of deaths by suicide, excuse me, for youth ages 10 to 18. And we see that the solid line is youth who live in metropolitan areas, and the hashed line is youth who live in non-metropolitan areas. And we see a gap here. And in fact, the gap is actually increasing over time. If you're comparing the arrows on the left side of the screen to the arrows on the right side of the screen, we are seeing an increase in this gap, and it's not insignificant. When we're looking at the number of deaths per 100,000 youth, we're comparing, 7 to 5 deaths per 100,000 youth. And before you think that this is, some way that, we're classifying counties or we're grouping areas together, I broke this down even more specifically into types of counties. So the red lines here indicate rural counties, and the black or gray lines indicate urban counties or metropolitan counties. Well, I'm only looking at 2018 to 2021, so it's a little shorter snapshot, but still on the y-axis, we have the rate of deaths per 100,000 youth. So I'm going to flip back to the previous screen really quick and look at the scale a little bit. So we're going from 0 to 10 deaths per 100,000. And if we move on to looking at it more granularly, we actually see that the most rural youth, this kind of tiny dot line, actually has almost 12 deaths per 100,000 youth. So we're actually seeing the average is right about here in the middle, but we're actually seeing a real sort of dose response gradient when we're moving from urban to more rural. So this is a pretty big gap that we're viewing. Lest you think that this is a national problem or it's not hitting our local areas, I pulled data last night from CDC's Wonder mortality database just for Washington State. And so that's here. It's organized a little bit differently. These are 2016 to 2020. Again, same age range, 10 to 18-year-olds. And on the x-axis here is the rate. On the y-axis, we're starting with most urban areas, and we're moving down to most rural areas. The reason why we have no reporting here in this bottom non-core, non-metro area is because of suppression of data, because there are so few cases and we want to make sure that people aren't identifiable. But nonetheless, it is important to note the data that we do have access to, the other non-metro micropolitan counties, we do see a much higher rate than we do say in the large central metro area. So this is, again, on the same scale as before, it's number of crude deaths per 100,000 youth, per 100,000 deaths. And this all has to do with, of course, mental health. And that's sort of the chutzpah, or the kind of the background behind what I'm talking about today. These are data from the DOH's Washington Tracking Network Adolescent Health Dashboard. The URL is at the bottom of the screen, as is for most of this, all of my slides today. And these are 2021 Healthy Youth Survey data for youth. And it just gives you an idea for those of y'all who are in Washington State to look at some of the geographic variation we have. This is an outcome of youth reporting feeling sad or hopeless in the last 12 months. And we see that the darker colors indicate a larger proportion of youth. The high end of the scale is 53.6%. So it's not insignificant. And the low end is 34.7%. The counties with the asterisks are suppressed due to lack of data or low counts. And so we don't want to make sure that folks in schools aren't identifiable. On the right side here, we have percent on the x-axis, and these are various categories of mental health outcomes for Washington State, Healthy Youth Survey. And just to kind of take a look at, this is not broken down by rural, urban, but just take a look at kind of the situation youth are facing today. So, we have slightly less than 20% of youth have considered attempting suicide in the last 12 months. We have over 60% reported feeling anxious in the last 2 weeks, and slightly less than 40% have reported feeling sad or hopeless. So this really is an issue. These data are reflected nationally as well, but I wanted to kind of pull some local data because I'm based in Washington. These are broken down by rural urban status. And so on the y-axis, we have percent of 10th graders. On the x-axis is over time. And these are the percentage of youth, again, Healthy Youth Survey data. So these are conducted in high schools. Percentage of youth who seriously thought about attempting suicide during the 12 months prior to the survey. And we do see a rural-urban variation within Washington for these precursors to suicide or mental health metrics. And so we do see for rural Washington youth, a higher proportion of rural Washington youth indicate that they are seriously or have attempted suicide in the last 12 months versus all youth in the state. So, this brings us, so I've established that there's an issue or there's a concern. And so now I want to kind of talk about rural urban disparities in access to care. I'm a health services researcher. So in the field of health services, we're really focused on the metrics of access, quality, and costs of healthcare. And I'm very interested personally in ensuring that there is equitable access to healthcare services for all, including those who are located in various geographic areas. And so I'm interested in this rural-urban disparities or inequities in access to care. Here is a map of the United States, and it's indicating HPSA scores for mental health. And so HPSA scores are a way to determine need for healthcare services. It's conducted by HRSA, these numbers are put out by HRSA. And these data from 2021, but they don't change significantly over time. The green cells are urban or rural cells, and then the blue cells are urban cells. And if a HPSA score is greater than 15, that indicates a high need for mental health services. And so the dark colors are indicating that there is a high need area. And so we do see quite a bit of dark green. This is just to kind of show the kind of scope of the issue across the country. This is in Washington. And so this is November 2022 data looking at, health professional shortage areas for mental health. And the dark counties indicate that the entire county is a mental health shortage area. And so anybody who's familiar with Washington State knows that this is the Puget Sound area. This is Pierce, King, and Snohomish counties. So part of Pierce and Snohomish counties are shortage areas, same with Spokane, and then also down here. And then none of King County is considered a mental health professional shortage area, but the rest of the entire state is. That is not to say that access to healthcare is easy in King County or in areas where it's not a mental health shortage area, but this is to say that we know that there are a wholly lack of, and I don't actually have the data in this presentation, but there are no psychologists and psychiatrists in many of these counties. There are no psychiatric mental health practitioners, and there might be one or two counselors. And so these are entire geographic areas that cover 1/10 of our state, and we may not have more than a handful, if any, mental health providers for a lot of these areas of our state. And so that brings us into this idea of the rural behavioral health workforce. And these are hot off the presses. This is data that was published, it just came out a couple of days ago, actually. And so I'm going to walk you through it. So here in the first column are social workers, our professions. And then the county type is the next column. And so the rural counties are white. The urban counties are shaded blue. And this is over time. So let's just for a moment look at 2021. So these are the percent of counties that don't have behavioral health professionals. And we'll take counselors, for example. So 18.4% of rural counties do not have a counselor compared to 4.6% of urban counties. We could look at psychiatric mental health nurse practitioners. 68.5% of rural counties do not have a psychiatric nurse practitioner in the country. This is national data, compared to 31% of urban counties. So we do see, if we're comparing these gaps, we are seeing a gap between rural and urban. I do want to make note that we do see a decrease or an increase of services, but a decrease in the percent of counties that lack a behavioral health provider over time. So in 2014, for example, in rural communities, 31% of rural communities did not have a social worker. Now we're at 22%. So we're making improvements, but we are still, there is still a gap. And so that's important to note. Here is looking at the number of behavioral health professionals per 100,000 residents. Again, let's just focus on this far right column for now. So take psychologists, for example, in rural counties, 15.8% of counties, there are 15.8 on average, 15.8 psychologists per 100,000 residents in rural counties compared to 39.5. So this is adjusting for population size. It's not adjusting for distance to travel, which is a big deal in rural, but it does adjust for population size, and we are seeing a disparity. I think that there's a shout out to Chihuahua. Awesome. Okay. So moving on to sort of what I'm going to talk about today. So I'm interested in access to care. And for a number of years, I've been working with a group called the Rural Alliance, which is a group of superintendents throughout the state who focus on access, improving access to services, not just health services, but AP classes in rural schools. And so trying to band together the rural schools and say, you know, it's really important. We might have only 50 kids in our high school, but it's really important we provide these services. And so I've been working with them and talking about what sort of services we have in rural schools in terms of mental health. We've already established from the data I've showed you before that we have a need for mental health services in rural communities. There are kids who we have a higher percentage of mental health conditions. We have a higher percentage of suicidal ideation in rural communities. We also have a lack of services. So my thought was, well, what about reaching kids through schools? And I have a whole sort of line of work that's not really research related, but more sort of outreach and connecting rural schools with counselors via telehealth and whatnot that I'd be happy to talk about. Anybody, my email address is on the last slide. But for this, I was using national data to look at whether or not there are geographic disparities in the availability of mental health services in U.S. public schools. And so I used actually a crime database, which public health folks don't typically use, but they do ask some really great questions. And so it's called the School Survey on Crime and Safety. This data was published. So this project or article was published in the American Journal of Preventive Medicine last fall in 2022. Shockingly, the data is from 2017 and 2018. And so they really lag putting out the data for us. And so they actually have 2019, 2020 data that they haven't released. And I email them about once a month and say, hi, you know, are these data available yet? And they aren't. But for 2017, 2018, we're looking at a cross-sectional analysis and they asked the superintendents of these schools whether mental health services were offered, what factors limited services, and then, of course, we looked at rurality by schools. And my major outcome I was interested in was the likelihood of providing mental health services comparing rural versus urban schools. And so a little bit of breakdown of what this kind of school breakdown looks like. 27.3% of schools were classified as urban. 33% were classified as suburban, and then the remainder were either small town or rural. So rural is that kind of quarter red slice there. And again, rural is red here, and this is showing the percentage of schools that have mental health services. So on the y-axis, we have percentage of schools, and in the first cluster right here, the first cluster of bars here is the percentage of schools that offer diagnostic mental health assessments. And we do see that 58.4% of urban schools offer those services versus 44.3% of rural schools. So we do see this sort of, again, dose response gradient here. As we get more rural, proportionally fewer schools offer these services. We don't see that fact with mental health treatment. So we don't see any sort of statistical variation across the rural-urban gradient in terms of whether or not schools offer mental health treatment. We also asked schools, what were some barriers in providing mental health services, which is a pretty cool and creative question actually to ask. And what we found is that along this sort of rural-urban gradient, as we moved more rural, there was a higher proportion of schools that indicated that their barriers were inadequate access to mental health professionals or inadequate funding. So these were statistically significant in a trend line, meaning that there was a trend as we went more rural, proportionally more schools indicated that funding and access to providers were barriers. Really neat, as somebody who lives in a rural community, is that there was a statistically significant trend decreasing as we get rural. So the lack of community support, proportionally fewer rural schools indicated that that was an issue or a barrier in providing mental health services. So in other words, as we get more rural, schools are less likely to indicate that lack of community support was a barrier. And that's really nice because there is this sort of stigma that there is stigma around mental health in rural communities, and communities don't necessarily support mental health provision of mental health services for youth. And actually, these data are counter to that and indicate that communities are not the barrier to providing services in rural. It's access to professionals and access to funding. And these are some regression results. So we're looking at so this is the likelihood of schools offering diagnostic mental health assessments compared to urban schools. And we see that here, let's just take this box on the far right, 0.81, that indicates that rural schools were 19% less likely to offer diagnostic mental health assessments than urban schools. So similar to the trend line I was showing before, these are just the stats to indicate that. We don't see any statistically significant differences between rural and the most rural and the most urban schools in terms of treatment. Okay, so then what about potentially using, I'm gonna let, if there is anything happening in the chat, please let me know, Megan, because I'm having a hard time trying to keep up if needed.
I'm not seeing anything. You're good to go.
Okay. Thank you. And so my thought is, well, what about using mental health or using technology, telehealth to access or improve mental health access in rural communities? And this really came to the fore during COVID. And so what we saw during COVID was, kind of the first 6 months, people saying, oh, great, we're gonna reach these. We know that rural kids are really struggling. We're gonna reach them through telehealth, telemental health, teletherapy. We're gonna get them counselors. And unfortunately, that didn't really work out. So it just says, this is a slide that I had created before. Can telehealth close the rural gap in access to mental health services? Many researchers in many articles were saying, oh yeah, telehealth is a great way to reach rural communities. To which my colleagues and I decided to write a bunch of letters to the editor in various journals, the Journal of Adolescent Health, the Journal of Rural Health, JAMA Pediatrics, pushing back on this concept because it sounds great for someone who lives in an urban area. Yes, let's reach these high need kids via telehealth, but it's a problem if we don't have access to broadband. And that remains an issue in Washington and rural communities throughout the country. There was one article that was focused on, it was in the Journal of Rural Health, and it was saying, well, let's look at the Navajo Reservation. We can reach these high need kids and adults via telehealth during COVID. And so this was in our letter to the editor that we submitted, indicating the lack of broadband. So that as the colors get darker, these are the percentage of households within these census tracts that lack broadband. And we see that up in some census tracts over here, and then right across the center here, 81 to 88% of households do not have broadband. And in fact, most households, all of these that are colored, are over 58% of households don't have broadband services. And this was back in 2020, so relying on late 2090s data, but nonetheless, it's an issue, and we just can't slap a solution of let's use the internet and assume that it's going to help all rural communities. And so to try to hit this home, because I was really on my soapbox about this for a while, because I know that, at least in my kids' school, roughly 40% of kids had internet access and 60% didn't here in Stevens County. And so it was an issue for us during COVID in terms of accessing education, but it also has implications for healthcare. And so I pulled data from OSPI during the spring of 2020. So that ill-fated spring where all the kids went to school in their homes and they closed down the schools. OSPI was conducting surveys with the school districts weekly and asking them about what percentage of your youth have access to broadband, what percentage have access to technology. And so I was really interested in using these data, and I worked with OSPI to gain access to look at the proportion of students who had access to technology and broadband. And then they also amazingly asked them what barriers there were to accessing broadband services for their youth. And so these are spring 2020 data. Again, here I tried to color all the rural it's kind of this cougar red, crimson here. So the rural school districts are shown in red. And on the y-axis is the percent of school districts, or sorry, percent of students. And so here, this first one is 66% of rural students had access to a desktop or computer compared to 76% of urban students. And as we move on, roughly equal percentage had a tablet or smartphone, but we do see significant differences here in terms of the percentage of youth in rural schools that had access to a device that was, quote, adequate for online learning. So a device that could stream actively in 2020. And then also reliable broadband, adequate to support synchronous real-time video. And so this is at the state level, 68% of students had access to broadband in rural school districts versus 84% in urban school districts. And so you're thinking, okay, this is school. That sounds like education. But again, this has huge implications for healthcare. If we're sitting here as public health folks or outreach folks saying, let's get kids therapy or counseling through telehealth, if they don't have broadband, putting aside lack of a private area in their homes or access to these devices, this is a major concern. So this is the state broken down by rural and urban school districts. So the rurals are kind of the red tone, the urban are the blue tone. And then this is just sort of a depiction showing the proportion of youth with access to broadband. And so the light kind of puce or the light tan color is less than 50% of youth in those school districts have access to broadband. The darker the colors are, the higher proportion, over 75% of the youth have access to broadband. And we can see that there are actually only 2 areas in urban counties where less than 50% of the youth have access to broadband. And that's right up here and right down here. But then look at the amount of sort of this cream color. And so we do have a lot of kids and a lot of youth who are underserved in terms of broadband access. And there's a lot of effort in our state since then going toward trying to improve access and a lot of federal efforts as well. Okay, so then I shifted gears a little bit and wanted to take sort of, I'm a quantitative sort of secondary data person, and I wanted to take that and say, let's get some community perspective. I don't think that all of the answers lie in data. I think we need to sort of talk to folks within rural communities and gain their perspectives. And so I put together a project that's using a method called group concept mapping to ask communities what their access to services look like and what barriers they face in terms of access. And so what we did is we asked our adults in Northeast Tri-County area, so Stevens Ferry and Pend Oreille counties, and we asked them to indicate or to provide a response to this prompt. Children and adolescents living in rural communities face many challenges in accessing mental health services locally. Things that inhibit youth access to mental health services include, and then we just asked folks to brainstorm. And they brainstormed 71, overall, we had 71 responses, 71 items. We also asked folks to rate them, and we asked them to rate them in terms of how common the challenge is in your community and how important that challenge is. How important is that challenge to address? And so some examples of what these responses might look like. So these are from rural communities and rural dwellers. A lot of them were, and I don't think I have the demographics here, but we really targeted school professionals, healthcare professionals, parents, and law enforcement. And we asked them to provide their ideas. And so things that came up were things like lack of responsive support, limited or no mental health services in the community. Also things like the youth are concerned about embarrassing their parents, or they don't have a trusting adult with whom they can confide. Certainly, poor internet connectivity for telehealth or broadband did come up, and so did lack of insurance that would sufficiently cover the costs. And so after we had these items brainstormed, we asked folks to sort them into buckets. And so what we wanted was to take all of these items and put them into conceptually similar groups. This is where the group concept mapping comes in. And so we asked them, Janessa, go out there and take these 71 items and kind of think about them, stew on them a little bit, and then kind of group them into the different buckets. And what we did then is we can use what's called multidimensional scaling and overlay the similarity matrices that everybody put together. So we have all these people saying this item and this item are grouped together so they're similar. And then somebody else says this item and this item are grouped together so they're similar. And that creates a distance between those points. And so then each of these dots represented on the screen now in this point map is a concept. It's one of the items that they brainstormed, excuse me. And it's located on a map wherein the distance between the points is indicative of how similar they are. So points 24 and 57 here indicate that they are closer, more similar conceptually, because people grouped them together more often, than say point 38 and 51, where 38 and 51 are very different ideas. They're all relevant. This isn't a judgment of how relevant they are, but this is a judgment of how similar these points are. And then what we can do is use what's called hierarchical cluster analysis and generate clusters. So if you kind of sit back and look at these points for a second and you blur your eyes a little bit, you can kind of see how they're like, there's a little bit, yesterday I used this phrasing, there's a little bit over here in New England. We've got some here down in the deep South, Southern California. And so we do have some groupings of points. And so what we can then do is create a cluster map. And then we work with our communities to identify what are these conceptual clusters? What do they mean? What are they what are the themes emerging from them? And that's where we came up with the labels. And so what we have sort of come up from this is based on the perspective of rural folks who live in rural communities. These are the issues that they're saying youth are facing in terms of accessing mental health services. So there are a lot of system level barriers, but there's also stigma. There are also financial issues, and there are also barriers within schools to accessing services. Now, remember, we also had them rate each of these points based on importance and how common they were. And from that, we can actually develop what's called a go zone. So here's the go zone for the barriers. On the x-axis, so imagine this is a graph, right? On the x-axis, so the horizontal axis, we have how common they are. And then on the y-axis, we have how important, or how big of, what I call the big of a dealness. How big of a deal is this issue? And the items that fall over here in this upper right quadrant are called the go zone. And so these are the most common, significantly more important. They're both common and important issues. And these really give us a way to prioritize then what to work on, right? When we're thinking about how to overcome these barriers, let's not focus on item number 2, because item number 2 isn't very common and it's not that important according to our respondents. But let's perhaps focus on item 4, which is very common and pretty important, or item 11, which is pretty common and very important, right? And so to give you an idea of how these, kind of sussed out and what bubbled to the surface in terms of the go zone barriers to serve mental health services, here are some of the system level barriers. And so these are ranked in terms of how common they are, but also their rank of importance is over here in the brackets. But just to give you an idea, the most common system level barrier was lack of public transportation. So, in our community, there's one bus that goes from Kettle Falls to Spokane, and I think it goes twice a day. And it takes quite a while, and I think it costs like $15. So it's a significant barrier in terms of getting to services, and especially when you're living in a town that doesn't have any therapists or doesn't have any services. Prior to conducting, so when we conducted this wasn't as much of an issue, but now with gas prices in our state being some of the highest in the country, it's actually putting a tax on people who have to drive to get services. And so that's creating even more of an inequity where folks have to pay, so we're paying, $5 a gallon for gas. But then if I have to drive 60 miles to go to therapy, that's a significant burden that could be overcome with some sort of transportation modality provided. But also things like lack of inpatient care nearby, lack of mental health providers. These are system level issues. Everyone grouped these together, and you can see they're all sort of related, right? These are kind of what people thematically grouped as as system level barriers. But we also have some knowledge and communication barriers. Most importantly, most commonly, not knowing how to get help, and then not knowing where to get help. There's also stigma, youth feeling like there's stigma against seeking help. So perhaps stigma doesn't really exist, but they feel like it does. I'm not sure. They're scared, they're intimidated. And then in terms of these school level barriers, there aren't after school programs that help provide extra support. They've identified a really common barrier is lack of providers or mental health staff or providers at schools. Schools don't provide these services. There isn't time at school to meet these needs, and then the kids leave. So these are all things that we can use to sort of address, we can start focusing on these barriers if we want to address some of the concerns in terms of access. The really neat thing as a sort of an academic for me was last spring, I worked with a couple of legislators and they'd reached out and said, hey, I heard you have these data. And I was super stoked because it's as a researcher, I don't often get to see like the next step of, okay, let's put this into action. Let's put this into reality. Let's apply this work. And so they were coming out and saying, so what are some of the barriers? And actually I did this entire process with facilitators. And so I'll talk about that in a little bit. And so I did the exact same process, but I asked, what can we do to improve? What are some ideas? Just sort of thinking this growth mindset of how can we, improve services? Let's not just focus on what's bad, but let's get some creative ideas from our communities as well. Because who knows rural communities better than the folks who actually live there? So taking you, kind of backpedaling a little bit, and then let's talk about a little bit about future directions. And because this isn't, things just don't, just put on the e-brake and we stop and then we're moving on to something else. Although I do have various groups, lines of research. But in terms of this, what are some future directions and areas to go? So I mentioned that I did this whole group concept mapping process when we're looking at ways to improve access to mental health services. And these are the clusters that folks came up with. So it was a 5-cluster solution. They came up with community-based solutions, policies and systems, education and life skills, healthcare, and school-based solutions. And here are some examples within each of those clusters. So for community-based solutions, building community health centers where anyone can receive any form of healthcare in one place. For healthcare solutions, develop and support school-based health clinics. Policies and systems, they classified as developing hotlines for diverse mental health needs. So not just suicide, but just sort of across the spectrum. Employing more or any mental health counselors in schools. And then destigmatize mental health by creating spaces for kids and adults to talk about it. And so I'm sort of working with these data and working on the concept map and going back and forth with community members to make sure that things are clearly delineated and that we can create some actionable items out of this. I see a note in the chat from Danielle. She says, do you have a reference or resource for the methodology? I would be happy to talk to you about that. And like I said, my method or my email is at the end of this slide deck, and I can put it in the chat maybe, or Megan could. But this is probably under my profile. But it's called Group Concept Mapping, and the app I used is called Group Wisdom, and I'd be happy to. I've done this a lot. My favorite work is this work, but I've also done it for my college, and I actually have been working with a group called the Rural Network, which is a prevention coalition in the state, and helping them with their strategic planning around identifying risk and protective factors for youth substance use in rural communities. And so that's what I was doing yesterday, was going through and like identifying their clusters and what cluster solution and how do the different factors suss out for risk and protective factors, which is a lot of fun because then they can take it and develop programming and educational outreach based on those things. So I love it. It's really fun to see things be applied as a sort of someone who sits in a office all day. So other important topics. In 2023, in spring 2023, the Surgeon General came out with an advisory on social media and youth mental health. And I think this is a really important thing not to overlook when we're talking about youth mental health, and something that we need to address moving forward. And then I was going to put sort of a whole Janessa's brain dump of various ideas on here, but I thought it might be better to sort of think as a group and maybe put in the comments, the chat, or the Q&A, like what other suggestions do you think are important for looking at rural youth mental health? You know, I have sort of a whole host of spectrum. I did some work actually on youth suicidal ideation and cannabis. So I could put the citation for that paper in there because I know this is a overdose prevention and harm reduction series. But you know, I'm interested in this issue holistically. I'm really focused on improving access to care. But I think that this is such a multifaceted issue that I'd love to hear sort of other perspectives in terms of barriers. Somebody asked about American Indian populations as a subgroup. I haven't in particular, especially the data sets that I've been using recently, those respondents have been suppressed. So I've been using some national data from NIH. And so I haven't particularly looked at those populations. I think that there is some really great work being done and some good partners down in Portland who could, you know, the Northwest Portland Area Indian Health Board, who are really focused on that, and then some other researcher groups. But I'm personally haven't focused on working with tribal communities as a subgroup, but their access to services is potentially even more complex. An outreach bus for mental health and doctor's appointments. That's a great suggestion, Stacy. Excuse me. And there is something called the rural resources here in Northeast Tri-County where folks can call and, you know, so I have older adult neighbors who don't drive and have vision impairment, but they have doctor's appointments for various conditions. And so they'll call rural resources and the van will come pick them up and take them to Colville, 35 minutes away, and whatnot. And so that's an option. One thing that came up when we did, prior to this, we did a bunch of Key Informant interviews and then some small focus groups. And one of the issues that came up was if, you know, kids can't go to therapy in, say, Chewelah, or it's really challenging because then other kids will know that their car is there, because, you know, we're not talking a big urban area. And so, you know, everyone knows when I get my haircut because I'm parked outside of Terry's shop in town. And so, you know, kids are concerned that other kids will know. And so I wonder about the outreach bus. One suggestion I had from someone down in the Spokane tribe was centers like the Camas Center or the Benoit. They have these sort of large community centers that have gyms and childcare and medical care and dental care and, you know, community activities all in one building. Big Brother, Big Sister, or Boys and Girls Club, you know, like all of these programming in a single building. People can walk in anonymously and they could be working out, or they could be going to see their therapist, or they could be going swimming at the swimming pool. And so that's some nice anonymity that it provides if kids are worried about the stigma of being seen. And that was a suggestion they had with, I think it was their medical clinic or their, you know, attached to their school or something. And they were talking about Big Brother, Big Sister, or Boys and Girls Club or something like that. And being attached, and they would be able to avail themselves of those opportunities, but at the same time, then also be able to be somewhat anonymous in terms of what folks might see. I wanted to wrap up. Please write more in the chat, and I love talking about this sort of thing. I think that this is all really important, and I think that we need to start thinking a little bit more creatively about our rural communities and ways that we can improve services. But other important, so I wanted to kind of touch on, before I let you guys go, a quick selection of helpful Washington resources. So somebody in the Q&A prior to the session, so yesterday, had posted a question about how to find services or how to find therapy or how counseling for kids who needed it. And I think the onus is on me to make sure that folks have those resources. So I'm going to do a quick, you know, high-speed tour through a bunch of resources, but you do have my slides and there are URLs on all the slides. And please reach out to me if you have any more questions. I am not an expert in terms, I'm not a therapist or a mental health provider, but I care deeply about this issue and trying to improve access for our kids. And so I'm happy to do what I can to try to get some answers. Yesterday, I believe you had a speaker from Seattle Children's. There is a mental health referral service operated through the Seattle Children's. It's funded by the Healthcare Authority. It's a free referral service. and it will provide referrals for youth 17 years and under in Washington State. They provide language services and interpretive services. It's available for families. It's called the Partnership Access Line. So this is a place that folks can go if they need a referral to mental health services. I haven't used it personally, and I know that there have been concerns that rural communities haven't taken as much advantage of this as they could. And I think getting the word out is the most important thing. And so, letting rural families know and that they can access this service and they can get referrals through there. The 8 Healthcare Authority has information about various treatment options that are available for youth in terms of behavioral health services. Again, URLs here at the bottom. And so I'm happy these will be posted and you'll have that information. And then this is a DOH website. I tried to put all the sort of DOH stuff at the front end or the state stuff at the front end. And these are helplines and resources. They're geographically limited in some cases. So this is the peninsulas, Clark County, North Puget Sound, South Sound. But here's Thurston and Mason counties. But if you do live in those areas or know folks who live in those areas who need access to a helpline or a crisis line, then these are some options for you as well. There's also a nonprofit. Their mission is to unite Washington family leaders in behavioral health care and strengthen partnerships between children, youth, and families. They provide resources, support, and events. So it's called Washington State Community Connectors. This is some information. So, they provide leadership, the family network, various annual events, and then a family navigator substance use disorder program. So that's also an option that is available. Their healthcare authority is partnering with Kids Mental Health of Pierce County and the Developmental Disabilities Administration to stand up 3 regions every year for the next 3 years for this, providing resources and information and training and events and connections around mental health in Washington. And so this is sort of a map of, so in July 2023, they were supposed to stand up sort of the North Central Spokane region, Thurston Mason, and then the Great Rivers section. And then the other darker kind of Greater Columbia, Southwest Pierce, and Salish, Kitsap, these areas are all stood up already. So that's available at kidsmentalhealthlaw.org. PAVE provides a behavioral health toolkit. This is also a nonprofit organization looking at folks in terms of school-based services. They also have events down in Olympia, so that's something to look at. There's a free helpline run by teens for teens called Washington Teen Link. So that's an option that kids can reach out to. Again, here's the 988. This is the big progress that we've made recently. So this is a free confidential crisis line that folks are able to call. They can also chat, which believe it or not, I'm also sort of not of that generation, but I would rather prefer chatting than calling folks. So, or texting. So that's an option as well. I know I'm moving through this quickly, but folks can, the slides will be available. This is Teen Line. Again, it's run by a nonprofit called the D.D. Hirsch Mental Health Services, but an option for services. And then I usually put this at the end of all of my talks, especially when I'm giving talks to youth, to make sure that they have these available. And so I sort of leave these typically on the slide, and so they can jot down the numbers. And these are changing over time, but those are just some big brain dump of resources. I'm not, again, the end-all be-all expert, and I'm happy to have suggestions of more resources available. They do vary geographically, but I think the more information we have, the better. So this is my email address. It's just janessa.graves@wsu.edu. And I see someone says, Eastern Lewis County, many people in the area don't trust outsiders. Most providers aren't from the area. How do we get providers and might commute to rural areas to be more intertwined and stay within the community? Local hospitals have a hard time getting and keeping providers because there isn't a real alert of the area. I can attest to that. My husband's a healthcare provider out here. And so I definitely am aware of some of the challenges associated with that. I think they're doing more in terms of some loan repayment options to get folks to go to communities. I mean, that's why we moved here, for, loan payment and been here now over a decade. And it wasn't the plan, but it takes a little bit of time to sort of fall in love with an area. And so that's a piece. I do know from friends who are psychologists that it is challenging to work and live in the same community because of some of the issues that you're faced with in terms of services that they provide. But it could be that it's somebody who lives in a neighboring town 25 or 30 miles away. And so they're still in the county, they're still in the community, they're not commuting in from, the big city, but, so they understand where the patients are coming from. I think importantly, and this is loaner payment contributes to this, is building your own. So building up our youth today, providing them with the education and the resources and the support so that they can go and get training and then come back to their communities. And so, so I joke, like, it wasn't the plan to live in this community, but I've lived in rural communities my whole life. And it would be strange to not live in a rural community for me. So even though I'm not where my parents are in Illinois, I think that there is that element that, if you have, we can do better as educators at the, primary, secondary, and then post-secondary levels to support our youth and rural youth in particular, to provide them some options. And then, we can train them and have them come back to their communities. And maybe they live in, Chewelah, but they work in Colville, or, they live in Republic, but then they work in Chelan, or, I'm talking about my areas, but I think that there are some options, and then people really have that perspective as well. So I think that is a great option. Somebody says in Darrington, they have a lack of housing, so it makes it hard to get providers in the area. And that's definitely, I do a lot of work with sort of as a separate line of work with local health districts. And I know that housing in particular is an issue. And I know that lots of health departments are aware of that. And are aware, and municipalities, at least our municipalities are focused on that. So that is it. I'm going to scroll back to this other side just so folks have the resources in front of them. And then please feel free to keep the questions coming. I think we have a little bit of time. We have 8 minutes. Legislation, there was a so I love that you're talking about State Bill 5710 because I wrote it. And so that was a project that I ran a couple of years ago, where I wrote a grant for a mental health therapist to sit at ESD 101 and telehealth into Odessa and Northport and Wilbur and all these rural school districts, and provide in a private room in the school districts a Zoom sort of situation where kids could go in because they can't get a therapist to come to live in Odessa or live in Northport, but kids are comfortable enough. It's not ideal. I want providers living in communities personally, because I love rural communities. I want them to thrive, but as a stopgap. And so they had put together a bill for this. So thank you for mentioning that, Harrison. So I helped write that bill to provide those. It was a grant through OSPI that they were talking about. So schools could apply for that grant. I'm not sure what the progress is or where it went, but I think that trying to think creatively like that is key. There are a lot of barriers, and I don't want to be sort of the negative, have a negative mindset, but, we do need to be realistic that, well, we can say kids can get services at home through telehealth, but then they have very thin walls and their parents are there. Can we think creatively about meeting kids where they are, providing them the services in the format that they want, even if it's on a walk, and they're talking to their therapist on their earbud or on their headphones, that's providing them services and meeting them where they are. And it might not look like our experience or our parents' experience of getting care services or not getting services at all, but we do need to make sure that they're getting services that they need. Trying to make sure that I'm following up. They're having a panel discussion on TeenLink tomorrow with a couple of call takers, so that's amazing. That's awesome. And lack of providers, I think is a real problem as well. We have a resource to guide programs on my programs page at DSHS. Thank you, Autumn, for sharing that. So that's in the chat, everybody. And then mobile efforts, that's a great idea, a dental van. And I think that we've talked about getting like a RV type caravan type thing where then people could go in, sort of like the Bloodmobile, and get services. So I'm around. I want to make sure that I'm answering all of the questions, but please feel free. My email address, thank you so much, Megan. It's in the chat. And thanks everybody for being here. I know it's a little bit, slightly off topic for overdose, but it's all certainly really critical and important and related. I did see Dr. So with regard to American Indians populations, I did see Dr. Phillips' question, and I haven't particularly worked with tribes myself. But I think that that's a really critical population to focus on. Certainly a lot of folks who live in rural communities have tribal affiliations, or are enrolled tribal members, even if they might not live on the reservations. But ensuring that, I think that's some of the highest need groups in our communities. So, and I know this is for folks who are not in Washington, a lot of these things do apply elsewhere. And so if anyone wants to talk about issues throughout, please let me know and I can reach out. So.
All right. Thank you so much, Dr. Graves. And it looks like we're just getting a lot of thank yous in the chat now. For any of you who still have lingering questions, you have Dr. Graves's email, or you can continue to put those questions into the Q&A and we can direct them to Dr. Graves after the session ends. Otherwise, we can give you back a few minutes of your morning before you head to your next session. Dr. Graves, thank you so much for spending your time with us this morning. We really appreciate all of the research that you've done and the information that you shared with us. So thank you.
Yeah, I'm happy to be here. So happy.
All right, everyone. We will see you all in the next sessions. Have a great day.